a risk
Specific for head and
factor.
neck, the
Occupational
most commonly
exposure to
known
chronic
risk factors would
inhalants can
be
be a risk
alcohol,
factor for
tobacco, and
developing
the
cancers
neck,
of the nose
chewing,
and
or gnawing.
sinuses.
But
Genetic
in some head and neck
predisposition,
cancers, particularly
nutritional
for the
status
oral
of the
cavity, the
patient, and
oral
infections,
hygiene, poor
especially
oral
HPV
hygiene,
and
the use
Epstein-Barr
of rigid
virus,
dentures is
have been
also a risk
associated
factor.
with head and neck cancer.
Occupational exposure to chronic inhalants can be a risk factor for developing
Specific
cancers of
types
the
of head and
nose
neck
and
cancer
sinuses. Genetic predisposition,
for everyone's
nutritional status of
information
the
would
patient,
involve cancers
infections,
afflicting the
especially
nose and
HPV and
paranasal
Epstein-Barr
sinuses,
virus,
the
have been associated
nasopharynx,
with
the
head and
oral
neck
cavity,
cancer.
including everything from the lip, the tongue, the buccal mucosa, the
Specific type
floor
of
of
head and neck
mouth, the
cancer
alveolus, and the hard palate, they all fall under oral
for
cavity
everyone's
cancer.
information, would
Oropharynx
involve
cancer
cancers
in the
afflicting the
tonsils
nose
and
and
soft
paranasal
palate,
sinuses,
larynx
the
and
nasopharynx,
hypopharynx,
the oral
skin
cavity,
of the
including
face and neck,
everything from the lip,
ear and
the
temporal
tongue, the
bone,
buccal mucosa, the floor
salivary
of mouth,
glands,
the
and
alveolus,
thyroid
and the hard
cancer,
palate,
they all fall under
cavity
the
cancer.
specialty of
Oropharynx
head and neck
cancer
cancer.
in the tonsils and soft palate,
It is very
larynx and
important for, especially
hypopharynx,
for the frontline
skin of the face and
physicians,
neck,
those the
ear and
primary care
temporal bone,
physicians,
salivary
to
glands,
have a
and
very
thyroid
thorough history
cancer.
and physical exam
They
to
all
increase
fall
their
under
index of
the
suspicion.
specialty of head and
So
neck
it's very
cancer.
important for the signs and symptoms,
It is very important
family
for, especially
history,
for the
the risk
frontline
factors which I
physicians, those
enumerated earlier,
primary care
and doing a
physicians,
complete ENT
to
examination
have
after
a
they've been
very
referred
thorough
to the
history and physical
specialist.
exam to increase their index of
The
suspicion.
common signs and
So it's
symptoms
very
for head and neck
important for the
cancer:
signs and symptoms,
a painless growth in the neck,
family history,
whether in the
the
anterior
risk
neck or in the
factors which I
lateral neck.
enumerated
It's even
earlier,
more suspicious if
and
it's a
doing a complete
painless
ENT
growth.
examination after they've
If
been
it's a
referred to the
painful growth, more or less
specialist.
it's probably infectious, but a painless
The
growth is
common
more
signs and
suspicious for cancer
symptoms
or
for head and
tumor.
neck cancer:
Intermittent
a
epistaxis,
painless
especially
growth
if
in the
it's
neck,
persistently
whether in
on the
the
same
anterior neck
side,
or in
on
the
one side
lateral neck.
only.
It's even more
Bleeding,
suspicious
like
if it's a painless
hemoptysis from the
growth.
mouth or the
If
ear,
it's a
your
painful
blood-tinged
growth, more or less it's probably
sputum,
infectious,
or
while
when
a
you have
painless growth
blood
is more
whenever you
suspicious for
spit,
cancer or
those are
tumor.
suspicious signs.
Intermittent epistaxis, especially
Persistent
if it's
progressive
persistently
hoarseness.
on the same side, on
Everyone
one
can
side
be
only.
hoarse after a bout of orgy
Bleeding, like
or
hemoptysis
after a
from the
night at
mouth or
the
the ear,
karaoke,
your blood-tinged
but persistent
sputum, or when
for
you
2 weeks
have blood
or
whenever you
even
spit.
longer.
Those are
And more
suspicious
importantly, if it's
signs.
progressive, those are
Persistent
suspicious
progressive
signs for
hoarseness.
cancer in the
Everyone can be
voice box
hoarse
or in the
after a bout of
larynx.
orgy
A
or
non-healing
after a
ulcer in the
night at
oral
the
cavity, the ones
karaoke,
we call
but
singao. They're
persistent
most often in the
for two
tongue,
weeks
especially
or
in the
even
lateral side
longer.
of the tongue,
And
but they can
more
also be
importantly,
present
if
in
it's
the buccal
progressive,
mucosa, in the
those
floor
are
of mouth,
suspicious
in the
signs for
alveolus.
cancer in the
If it's
voice
more than
box or
two
in the
weeks and it's still
larynx.
there,
A
it's
non-healing
already
ulcer in the
suspicious, and
oral cavity, the
it's
ones
time
we
to
call
refer to the
singao.
specialist who will
They're
probably
most
do a
often in the
biopsy.
tongue, especially in the lateral side
Persistent
of the
nasal
tongue, but they can also
obstruction,
be present in the
especially
buccal
if it's
mucosa,
always on the
in the
same
floor of
side,
mouth, in the
it's more
alveolus.
suspicious.
If it's more than two
Slowly
weeks and it's still
progressive
there,
dysphagia or
it's already suspicious,
odynophagia.
and it's time to refer
Slowly
to the
progressive
specialist who will
dyspnea. The
probably
key
do a
word here is
biopsy.
progressive and slow. Because if
Persistent
it's
nasal
fast, it's probably
obstruction,
just an infection.
especially if
But
it's
if it's a
always on the
slow
same
progressive
side,
process,
it's more
probably means
suspicious.
there's a tumor growing
Slowly
inside.
progressive
And for the
dysphagia
airway,
or
whenever you hear
odynophagia,
stridor, that's
slowly
already a
progressive
suspicious
dyspnea. The keyword here
sign
is
also.
progressive and
Loosening
slow.
of
If it's
dentition,
fast, it's
probably
probably
because
just an
a tumor is
infection.
growing
But if it's a
underneath the
slow
roots of the
progressive
teeth.
process,
That's why
it probably
your
means
teeth
there's a
become
tumor
loose.
growing inside.
Any
And
growth
for
or
the
bulge in
airway,
the mouth,
whenever you hear
face, neck
stridor,
area,
that's already a
otalgia that is
suspicious
not infectious in
sign also.
etiology,
Loosening of
and
dentition,
one-sided
probably
facial
because a
palsy. These are
tumor
the
is
most
growing
common signs of
underneath the roots
head and
of the
neck
teeth.
cancer.
That's why your teeth become loose.
So
Any
when a
growth or
patient is
bulge in
referred
the
to the
mouth,
specialist or when they
face,
come to our
neck
clinic,
area,
uh,
otalgia that
often
is
than
not
not, we
infectious
do
in
an
etiology,
endoscopy.
and
We look at
one-sided
the
facial
insides, the
palsy. These
orifices
are
of
the most
the
common
head and
signs of
neck area,
head
the
and neck
ones that are
cancer.
difficult to visualize and examine by gross inspection.
So
The
when
nose
a
and
patient
sinuses, the
is referred to the
nasopharynx, larynx,
specialist
and
or
the
when they
trachea,
come
we
to
have
our
flexible
clinic,
scopes, rigid scopes. We can do them in
often
the
than not, we
clinic
do
office only,
endoscopy.
or sometimes we
We
have to
look
bring the
at
patient
the
up to the
insides, the
operating room,
orifices of
especially if we
the
have to do
head and neck
a
area,
biopsy
the
as
ones that
well.
are difficult to visualize and examine by
So
gross
the
inspection.
tissues we
The
get,
nose and sinuses,
either
the
from the primary
nasopharynx,
tumor or
larynx, and the
from
trachea,
a
we have
suspicious
flexible scopes,
metastatic
rigid
node in
scopes.
the
We
neck.
can do them in the clinic,
FNAB, or fine needle
office
aspiration
only, or
biopsy, and
sometimes we
core
have to
needle
bring the patient up
biopsy,
to the
we
operating
often
room,
do them in the
especially if we have to
clinic.
do
If we need
biopsy
more
as
tissue
well.
samples, we open up the tumor and
So
get
the
a
tissues we
sample
get,
through an
either
incisional
with
or
the
an
primary
excision
tumor or
biopsy,
from
and we
a
send them
suspicious
to the
metastatic node
pathology
in the
lab
neck.
for gross microscopic and
If not, the finding of
immunohistochemical
aspiration
staining
biopsy and core needle
studies.
biopsy, we often do them in the clinic.
Also included
If
in
we
the
need more
diagnosis
tissue
of a
samples,
cancer
we open up the
is
tumor and
imaging.
get
Now,
a sample through
the
an
slide
incisional
will
or
show you one
excision
CT
biopsy, and we
scan and
send
one
them to the
MRI.
pathology
In
lab for
some
gross
cases, you will need to
microscopic
do
and
both. The CT scan
immunohistochemical
is better
staining
for
studies.
bone
Also
diseases or
included
bone
in the
problems.
diagnosis of a
The MRI
cancer
is better for
is
soft tissue
imaging.
problems.
Now,
It
the
is
slide will show
never
you one CT scan and one
a
MRI.
checklist. It is
In some
more
cases, you will need to
as
do
an
both.
as
The CT
needed
scan is
basis for
better
the
for
patient, depending on what his or her
bone
symptoms
diseases or
are.
bone problems.
Now,
The MRI
what
is
else do
better
you
for
have to
soft tissue
do? Let's
problems.
say that your endoscopy, your
It is
biopsy, your imaging
never
all point towards a tumor,
a
and it
checklist.
turns
It
out
is
to be
more
positive. We can't stop
as
there.
needed
We will
basis for
have
the
to do
patient
additional
depending on what
workups, which we
his or
call
her
the
symptoms
metastatic
are.
workup, which includes
Now,
liver
what
ultrasound,
else
the
do you
chest
have to
x-ray, your
do?
bone scan,
Let's
and
say that your
possibly
endoscopy,
even
your
your
biopsy,
PET
your
scan.
imaging all point
What we
towards a
would like to
tumor
do
and
is
it
find
turns
out
out to
if
be
this
positive,
disease, this
we
cancer
can't
has
stop
spread,
there. We will
so
have to do
that we
additional
can
workups,
establish
which we call
the
the metastatic
staging
workup,
right
which
at the
includes liver
diagnosis.
ultrasound, the
This
chest
will
x-ray, your
matter
bone
very
scan, and
much to
possibly
us in
even
the
your
eventual
PET scan.
management of the
What we would
patient.
like to do is find out if this
So after
disease,
doing
this
everything
cancer
from
has
your
spread
history,
so
taking physical
that we can
examination, your workup,
establish
you
the
have all the information you
staging
need,
right at the
then you can decide on
diagnosis.
the appropriate
This will
treatment
matter
for
very
your
much to
particular
us
patient.
in the eventual
So,
management of the
appropriate
patient.
treatment is recommended based on the following: whether
So
the
after doing
tumor is
everything from your
resectable,
history,
and
taking
depending on
physical
the kind of tumor,
examination,
on
your
the
workup,
prognosis of the
you have
tumor.
all the information you
And
need,
you also have to
then you can
discuss with the
decide on the
patient the
appropriate treatment
consequent functional
for your particular
deficits,
patient.
cosmetic deformities, and
So
psychological
appropriate
impact of
treatment is
treatment both
recommended
on the
based on the
patient and their
following:
family and
whether the
caregivers.
tumor is resectable,
The patient's
and
general health
depending on the
condition
kind of
have to be
tumor and the
considered as
prognosis of the
well,
tumor.
because
And
treatment
you
has
also
its
have to
side effects.
discuss with the
Whether it's
patient the
surgical or
consequent
non-surgical, it
functional
will have side
deficits,
effects and it will affect
cosmetic
the patient's
deformities,
general
and
health.
psychological impact of
Cost of
treatment, both
treatment
on
is
the
a big
patient and
factor,
their
especially
family
here
and
in our
caregivers.
country.
The
And
patient's general health
family and
condition
caregiver
have to be
support
considered
also
as
very
well,
important.
because treatment has its side effects.
Now,
Whether it's
both Dr.
surgical
Matsuo
or
and I sit
non-surgical,
on
it
a
will have side effects and it will
multidisciplinary
affect the
head
patient's
and neck
general health.
tumor team.
Cost of treatment
When
is
we
a
say
big factor, especially here
multidisciplinary,
in
we're
our
not just
country.
talking about one
And
surgeon, one radiation
family and caregiver
oncologist.
support
If you
also
look at the
very
list, there's a whole number, a lot of
Now,
people
both Dr.
involved
Matsuo
in
and
the
I sit
management
on a
of a head and neck
multidisciplinary
cancer patient.
head and neck
The
tumor
pathologist
team.
in the
When we say
diagnosis, the
multidisciplinary, we're
anesthesiologist
not
when
just
it
talking
comes to
about one
planning the
surgeon, one
surgeries
radiation
that the
oncologist.
head and
If
neck
you look
surgeon
at the
will do.
list,
We
there's a
also need to get the
whole number, a
nutritionist,
lot
the
of people
dentist
involved
involved.
in the management of a
Many
head
of
and
the
neck cancer
operations and
patient.
treatments that
The
are done for head and neck
pathologist in the
cancer will
diagnosis,
adversely
the
affect the
anesthesiologist
appetite,
when
the
it comes to
taste of
planning
a
the
patient. Therefore,
surgeries that
nutrition
the
becomes
head
very
and neck surgeon will
important.
do. We
And
also need to get the
later
nutritionist,
on,
the dentist
rehab will
involved.
come in, especially with
Many
voice
of the
rehab,
operations and
and
treatments that are
swallowing
done for head and
rehab.
neck
So
cancer
it's very
will
important that
adversely affect the
all members of
appetite,
the
the
team are on
taste
board
of a patient.
at the
Therefore,
very
nutrition
start
becomes
of
very
the
important.
patient's management.
And later on, rehab will come in,
So,
especially with
in
voice
general, for head
rehab
and neck cancer,
and swallowing rehab.
almost
So
always
it's
the
very
best
important
treatment
that
is initial
all members of the
surgery.
team are on
I
board
emphasize
at
on
the
the word
very
initial because
start
it doesn't,
of the
the treatment doesn't
patient's
end on surgery.
management.
It's the initial step of the treatment, but further steps have to be taken
so
after
in
surgery.
general, for
So as
head
a
and neck
general
cancer,
rule, we
almost
operate. We do
always the
surgery
best
if it's
treatment is
resectable,
initial
if it's
surgery.
possible.
I
Depending
emphasize
on
on the
many
word
things, the tumor
initial because
factors, the
it
patient
doesn't the treatment
factors.
doesn't end on
But that
surgery.
is the best
It's the initial
treatment if
step of
it's
the treatment,
feasible.
but
And then
further
later on,
steps have to be
after
taken
surgery,
after
we do adjuvant
surgery.
treatment.
So as a general
We offer
rule,
radiotherapy
we
with or without
operate.
chemotherapy,
We do
depending
surgery if
on
it's
many factors.
resectable, if it's
And as
possible,
part of the treatment, as
depending on
mentioned
many
earlier,
things: the tumor factors,
rehabilitation,
the patient
palliation, pain
factors.
management, and
But that is the best
psychosocial
treatment
support.
if it's feasible. And then later on,
Now,
we after surgery
radiotherapy
we do
may play
adjuvant
a
treatment.
role. It
We
may
offer
either be as
radiotherapy with or without
adjuvant or as
chemotherapy, depending
definitive, it
on many
depending
factors.
really on
And
how
as
early we
part of the
can catch these
treatment, as
cancers.
mentioned earlier,
Now,
rehabilitation, palliation, pain management, and
we add
psychosocial support.
radiotherapy to surgery if We find that on
Radiotherapy
final
may play a role.
histopathology, the tumor is
It may either be
aggressive,
as
or if there are
adjuvant or
positive
as
margins, or there are
depending
some
really on
unfavorable
how early we
features.
can catch these
Now,
cancers. We
chemotherapy
do
is helpful in
we
the
add
adjuvant
radiotherapy
management,
to
but it
surgery
really
if
acts as a
we find
radiosensitizer.
that on final
It is
histopathology
never
the tumor
usually
is
given
aggressive,
alone,
or if there are positive margins,
because
or
it
there are
is
some
not, it will
unfavorable
not control the
features.
disease
Now,
if it is given alone.
chemotherapy
So it's usually
is
given
helpful in the
with
adjuvant management, but
radiotherapy
it
or
really
after
acts as a
surgery. The
radiosensitizer.
exception, though, is in
It
a
is never usually
lymphoma,
given alone,
not the squamous cell cancers
because
that we're
it
talking
is
about.
not,
In
it will
lymphoma,
not control the
chemotherapy
disease
is
if it is given
the
alone.
best
So it's
treatment
usually
upfront.
given with radiotherapy or after surgery.
So as part of
The exception, though, is in a
surgery, you will see
lymphoma,
later,
not the squamous
it
cell
will
cancers
affect
that we're talking
everything
about.
from your
In
speech, your
lymphoma,
voice, your swallowing.
chemotherapy is
So part of the
the
team
best
also in
treatment
managing
upfront.
is the prosthetics team. When you have to do some reconstruction,
So
pain
as part of
management, the purpose of this
surgery, you
all
will see
is to
later,
help patient
it
integrate
will
back
affect
into society after
everything
all
from your
his
speech, your
treatment.
voice, your swallowing. So part of the
Now
team
we go to the
also in
specifics of
managing is the
management.
prosthetics
We talk
team.
about
When you have to
surgery.
do some
We'll go one
reconstruction,
by one
pain management,
with these
the
different
purpose of
kinds of
this
head and neck
all
tumors. We
is
start with
to
thyroid
help
cancer.
patient
An overwhelming
integrate back
majority
into
would be what
society
are
after
called
all
papillary
this.
and follicular carcinomas. These are generally behaved cancers
Now we go to the
with very
specifics
good
of
prognosis. They
management.
are compatible
We
with
talk about
life in
surgery.
general.
We'll go
Papillary
one by
carcinoma
one
usually spreads to the lymph
with
nodes
these
in the
different
neck,
kinds of head and neck tumors.
while
Let's start
follicular
with thyroid
carcinoma a little more
cancer.
aggressive
An
because it can
overwhelming
spread by
majority would be
blood.
what are
So
called
the initial
papillary and
treatment is
follicular
always
carcinomas.
surgery,
These
most
are
of the time
generally
a total
behaved cancers
thyroidectomy,
with
and
really good
depending
prognosis.
on
They are
patient's
compatible with
age,
life after
how
all.
big the tumor is,
Papillary carcinoma usually
surgery
spreads to the
is
lymph
always
nodes in the
followed
neck,
by some form of
while follicular
radiation, what we call
carcinoma is a little more
radioactive
aggressive because it
iodine. It's
can
something
spread by blood.
ingested, but it's
So
a
the
form of
initial treatment
radiation.
is
The purpose
always
of which is
surgery, most of the time a total thyroidectomy, and depending
to
on
kill
patient's
all the
age,
microscopic
how big the
disease.
tumor is,
And after that,
surgery is
this
always followed by
replacement, thyroid
some
hormone
form of
replacement,
radiation, what we call
supplementation, and
radioactive
lifelong
iodine, something
monitoring. So the
ingested,
point here is
but this is a
doesn't
form of radiation. The
treatment doesn't
purpose
end
of
with
which is
surgery, but will need further treatment. This is for thyroid cancer.
to kill all the
For the larynx
microscopic
or the voice
disease,
box, the
and after
hypopharynx is
that,
very adjacent to the larynx, so we
replacement,
discuss them
thyroid
all
hormone replacement,
together. This is your normal
supplementation, and
larynx, the
lifelong
glottis. You
monitoring.
can see the
So
true
the point
vocal
here
cords
is that
there. And
treatment
that is
doesn't
the
end with
entrance to the
surgery, but will need
airway.
further
So
treatment.
imagine if a
This is
tumor
for
is
thyroid
growing in the
cancer.
larynx, in the glottis area, there's
For
really
the
the
larynx or
danger
the
of the
voice
tumor
box, the
obstructing the
hypopharynx is very
airway,
adjacent
producing
to
your
the larynx,
stridor
so
and
we discuss them
eventual
all together.
difficulty of
This is
breathing
your
or
normal
dyspnea.
larynx, the
These are
glottis. You can see
samples
the
of
true
laryngeal
vocal cords
masses.
there.
These are small
And that
ones.
is the entrance to the airway.
So they
So
will
imagine
grow,
if
they
a
will get
tumor is
bigger
growing
if you
in the
don't
larynx, in the
identify them
glottis
right
area,
away, if
there's
you
really
don't
the danger
diagnose
of the
them
tumor obstructing
early
the
on.
airway, producing your
So
stridor
for
and
early
eventual
laryngeal
difficulty of
cancers,
breathing or dyspnea.
we can do
These are samples
conservation
of laryngeal
surgery, like
masses.
only part
These
of
are
the
small
larynx and not
ones.
the whole larynx can be removed.
So they will
And
grow, they
another
will get
option for the
bigger
patient
if you
is
don't
radiotherapy.
identify them right
Now,
away, if you
the
don't
outcomes for
diagnose
this
them
treatment are
early
similar, so it
on.
will depend on the patient's
So for
priorities, whether if
early
he wants
laryngeal
conservation
cancers,
surgery or radiotherapy.
we can do
We don't have to
conservation
go
surgery,
technical
like
on that, but
only
these are
part
the
of the
patient
larynx and
options
not
for
the whole
early
larynx can
stage
be
laryngeal
removed.
cancers.
And another
But for
option for the
advanced
patient
stage
is
laryngeal cancers, you
radiotherapy.
have your big
Now,
tumors.
the outcomes for this
More
treatment
often
are
than not, they
similar,
will
so
end
it will
up with
depend
a
on the
total
patient's
laryngectomy,
priorities,
removing the
whether he wants
entire
conservation
larynx, the
surgery
entire
or
voice
radiotherapy.
box,
We don't have
followed
to go
by
technical on that, but these
radiotherapy
are the patient
and
options for early stage
or
laryngeal cancers.
chemoradiation, combination of
But for
both.
advanced stage laryngeal
Or you
cancers, you
can
have your
also
big
do in
tumors.
not all
More
advanced
often than
cases,
not, they will
but
end
some
up with
select
a total
advanced laryngeal
laryngectomy, removing
cancers.
the entire
Another one of their
larynx, the
option
entire
is
voice box,
definitive
followed by
chemoradiation and
radiotherapy
reserving
and
surgery later on if
or
chemoradiation fails. We
chemoradiation,
do
combination
salvage
of both.
surgery.
Or you can also do in
So
not
this is
all
a
advanced
permanent
cases, but some
stoma.
select
The patient
advanced laryngeal
underwent a
cancers.
total laryngectomy
Another one of their
procedure.
option
So the
is
communication between the
definitive
nose, mouth, and the
chemoradiation
lungs
and
has been
reserving
disrupted because
surgery
the
later
larynx has
on
been
if
removed.
chemoradiation
So
fails. We
patient
do
will only
salvage
breathe through this
surgery.
stoma. This is permanent. Patient will have
So
no
this
voice.
is a permanent
Eventually,
stoma.
patient should be able to swallow with adequate rehabilitation, but this will be the consequence of a total laryngectomy procedure. This is a very high morbidity procedure, and it will greatly affect the patient's quality of life. So we don't want the patient's laryngeal cancer to become this advanced. So early diagnosis is very important.
But this will be the consequence of
Oral cavity cancer,
procedure. This is a very morbid.
as long as it's resectable, surgery is always the best, the initial treatment of choice, together with a neck dissection. So, understandably, the tongue, buccal mucosa, floor of mouth, hard palate, so it will affect your speech, chewing, mastication, swallowing, and also
As
breathing.
long as it's resectable, surgery is always the best.
So these are samples. The first picture is a tumor in the hard palate. The second picture is a tumor at the back of the tongue, posterior tongue, and then this one, the bottom picture is a tumor at the floor of the mouth.
And also
Okay, so imagine removing the tumors here. When we remove tumors, we do not just remove tumors, we get a large margin of normal tissue around the primary tumor. And you cannot just leave it like this, so you have to do some form of reconstruction. So we can get several flaps. This is a sample of a flap taken from the forearm, a radial forearm flap, to replace the part of the tongue that has been
We
removed.
get a large margin of normal tissue around the
So another sample, this is a through and through buccal mucosa cancer. So you can see the tongue right away. We need a bigger flap. We're getting a flap here from the lateral thigh to cover the defect. And this will be the patient's appearance after the surgery.
Removed.
So, as you can see, cancers in the head and neck are very visible cancers. And any treatment you do on the patient, it will be very visible. So, patient's quality of life is really affected. So, surgery is the first step of treatment, almost always followed by adjuvant radiotherapy with or without chemotherapy. And part of the treatment will be speech and swallowing therapy. You want them to slowly regain their function of swallowing and speaking clearly.
So surgery is the first step of treatment.
These are nose and sinus cancers. This is a diagram of I'm focusing on the maxilla, which is the biggest sinus. But you can also have sinus cancers in your ethmoid, sphenoid, and frontal sinuses. But the maxillary sinus is the most commonly affected. This is a total maxillectomy procedure. You remove the entire maxillary sinus. It's like a box. You remove all the walls of the maxillary sinus. These are samples of partial maxillectomy. You remove part of the medial wall. Anyway, in short, after you remove these tumors, it's debilitating. You'll have a hole in your hard palate. Sometimes you have to remove the eye. So really the quality of life is really affected, and part of the management is to reconstruct them. So we have our prosthesis team, So like this old man here, his eye has to be removed because it was involved by tumor, but a good prosthetics team will be able to manufacture for him an orbital prosthesis.
That looks quite like
Yes, so from afar, okay, so you really have to have a good thesis team also. This one is a hole in the hard palate, reconstructed with some kind of obturator, a denture you would call it, but it's not a regular denture. We call it a palatal obturator prosthesis.
Yes, so from afar.
Okay. Now, nasopharyngeal cancers, we do not operate on them, well, at least not in the Philippines. In some countries, they do for small nasopharyngeal tumors because fortunately, nasopharyngeal cancers, they respond very well to radiation with or without chemotherapy. However, they can present sometimes with big nodes. Patient will not know that he has a tumor in the nasopharynx. All he knows is that he has this big tumor in the neck. So our role here sometimes is we remove these tumors. But the primary site of the tumor in the nasopharynx are best managed by radiation.
So I go to radiotherapy. First, what is it? In short, it is really the use of ionizing radiation to treat cancers. We have big machines that look like CT scans and MRIs. Those are the machines that we use to treat cancers. The patient will not see anything, will not feel anything, but he or she will get treated. So how is it given? There are several ways how radiotherapy is given according to its role. One can be neoadjuvant, that means before the curative treatment. It was earlier mentioned that surgery is still the best treatment, but there are some occasions when we'd like to give radiation prior to surgery to be
several
able
ways how
to help the
radiotherapy is given
surgeon
according to its
in
role.
his surgery.
One can be neoadjuvant.
With
That means
the most
before the
common is
curative
probably
treatment.
adjuvant.
It was earlier
That
mentioned
means
that surgery
after
is still the
curative
best
treatment or
treatment, but there
after
are some
the
occasions when
surgery.
we'd like to give
Definitive
radiation
is
prior
where
to
surgery
surgery
is not an
to
option
be able
anymore,
to
but we
help
do
the surgeon
radiotherapy
in
since it
his
has the
surgery.
highest chance of cure, such as in
The most common is
nasopharyngeal
probably
carcinomas.
adjuvant.
But
That means
sadly, there's
after
also the
curative
role that
treatment
is
or after
palliative.
the
It happens a
surgery.
lot in the Philippines
Definitive
because
is
our
where
patients see
surgery
us
is not
at
an
very
option
advanced
anymore,
stages.
but we do
So we really
radiotherapy
cannot offer
since it has the
cures.
highest
Rather, we
chance of
will do
cure,
what we can
such
to
as in
control the symptoms
nasopharyngeal
or to slow
carcinomas.
down the progress
But
of the
sadly,
tumor.
there's also the role
Now,
that is
there's another way
palliative.
to
It
answer this
happens a lot
question,
in the
how is it
Philippines
given?
because our
According to the
patients see
precision of
us at
treatment.
very advanced
Conventional
stages.
radiotherapy
So we really
looks
cannot
something
offer
like this. If
cures.
your tumor
Rather,
is
we will
red,
do
it
what
will
we
hit
can to control
everything
the
within
symptoms
the
or to
blue
slow down the
box.
progress
Now,
of
with
the
3D
tumor.
conformal
Now,
radiotherapy,
there's
it's a
another way
little
to
more
answer this
precise. So
question, how
it
is it given?
conforms
According to
to
the
the
precision
shape
of
of the
treatment.
tumor.
Conventional
Intensity
radiotherapy
modulated
looks something like
radiotherapy, in
this. If
case
your
you didn't
tumor
see
is
that,
red, it will hit everything within
hits
the
only
blue
the
box.
tumor.
Now, with
Now, with
3D
image
conformal
guided, it's even
radiotherapy, it's
better
a
in that
little
it
more
hits only the
precise. So
tumor
it
and
conforms to
we
the
make
shape of the
allowances for
tumor.
movement. So when the
Intensity
patient
modulated
swallows, when the patient
radiotherapy, in case you
breathes,
didn't
so
see
the
that,
most precise treatment is
hits
image
only
guided
the
treatment.
tumor.
So what
Now, with
happens in
image guided,
radiotherapy,
it's
what
even
I'll try
better
to do
in
is
that it hits only
demystify
the
it for you
tumor
because many
and
patients are
we
scared of
make allowances for
radiotherapy because they
movement.
have
So when the patient
visions of
swallows, when the
Spider-Man
patient
and the Hulk
breathes,
when they're
so the
undergoing
most precise
radiotherapy.
treatment
When
is
actually
image
all that's going
guided
to happen
treatment.
is first a
So what happens
simulation,
in
which is a CT
radiotherapy,
scan,
what I'll try to do is
and
demystify it for you
nothing too
because many
special about
patients
it. We just
are
add a
scared of
few
radiotherapy
devices.
because they
And
have
then the treatment planning
visions
is
of
where the radiation
Spider-Man and the Hulk
oncologist
when they're
and the
undergoing
physicist will
radiotherapy. When
come up with
actually
the
all that's
best
going to
plan
happen is first a
wherein we would like to
simulation, which
hit
is
the
a CT
tumor
scan,
and nothing
and
else. And
nothing too
then
special about
the
it. We just
most
add a
tedious
few
part for the patient
devices.
actually is
And then the
when he or
treatment
she will
planning
come
is
in every
where the
day
radiation
for
oncologist and the
radiotherapy. And it's
physicist
not
will
even long therapy. It
come up
takes
with the best
about, what,
plan
15-20
wherein
minutes.
we would
Our
like to
only
hit the
requirement is
tumor
that the
and nothing
patient
else.
does not move
And
during
then
treatment so that it's the
the
same
most tedious
area
part for
that's
the
hit
patient
every
actually is
day.
when he or
So how
she
long
will
does it
come in
take?
every
As
day
mentioned earlier,
for
it's a few minutes.
radiotherapy. And it's
But
not
how many
even long
days does it
therapy. It
take? That
takes
really
about
depends on the
what,
intent
15,
of
20
treatment.
minutes. Our only
Sometimes if it really is
requirement is
just
that the
palliative,
patient
it will be a
does not
shorter
move during
duration. But if we're
treatment so
going for
that
a
it's the
cure, it will
same
generally
area
mean
that's
a longer
hit every
duration.
day.
In the head and neck
So
area,
how long does it
that's
take? Like
usually
mentioned earlier, it's a few
30 to
minutes.
35
But how
to
many
40
days
days
does it
even.
take? That really depends on the
Now,
intent of treatment.
will there be
Sometimes,
side
if it really is
effects?
just palliative, it will be a
Unfortunately, there's
shorter
no such
duration. But if we're
thing
going
as
for a
a
cure,
side
it will
effect
generally
free
mean a
treatment
longer
for head and neck
duration. In the
cancer.
head and neck
Whether
area,
that's
that's
surgery, radiotherapy,
usually
or chemotherapy,
30 to
the
35
patient will
to
feel
40 days
something. So
even.
we're pouring all our
Now,
efforts into
will
reducing
there be
those side
side effects?
effects. But yes, there will
Unfortunately,
be
there's
side
no
effects. For
such thing
radiation in
as a
particular,
side
it's a
effect
dryness
free
of mouth, the
treatment for
dryness
head
of
and
the
neck
skin,
cancer.
what
Whether
we call
that's
a
surgery,
radiation burn.
radiotherapy, or
If you will notice
chemotherapy,
this,
the patient will
the
feel
neck of the
something. So
patient
we're,
is
we're
quite
pouring all our efforts into
beefy
reducing
red.
those side
This is
effects.
because we'd like to
But yes,
hit the
there will be
lymph
side
node
effects. For
drainage.
radiation in particular,
Um,
it's a
Again, the
dryness of
dry
mouth,
mouth,
the
and
dryness of
because
the
it's dry,
skin,
the patients
what we call a
may
radiation burn.
develop
If you will
cough because
notice
it's
this,
dry.
the neck of the
But
patient is
then, if you
quite
think about it, what is
beefy
the
red.
alternative?
This
Not
is
getting
because we'd like to
treatment? I
hit
don't
the
think
lymph
that's
node drainage.
fair.
Um,
So
Again, the
really,
dry
I
mouth,
think the
and
take home
because
of
it's
both
dry, the
Dr. Matsuet
patients
and myself
may
is that
develop cough
the
because it's
earlier
dry.
that the cancer is
But
detected, we
then,
will
if we
have
think
more
about it,
options
what
to
is the
give a
alternative?
patient, and the
Not getting
patient's
treatment?
quality
I
of
don't think
life
that's
will be
fair.
much better. What
So,
does this
really,
require,
I think the take
therefore?
home of
That the
both Dr.
index of
Masuet and myself
suspicion
is
of the
that
first line
the
physician
earlier
should
that the
be high
cancer is
enough
detected,
so
we will
that
have
he or
more
she can refer to
options
the
to give a
experts
patient, and the patient's
if
quality of
needed.
life
As
will
mentioned
be much
earlier, if
better. What does
a
this
lesion in the
require
floor of of the mouth has been there for
The
2
index of
weeks, it is
suspicion of the
suspicious.
first-line
Refer.
physician
If
should
you've
be
tried to
high
give
enough
antibiotics for a
so
week and
that
nothing
he
has
or she can
happened,
refer to the
maybe it's
experts
already time to refer.
if needed. As
Now, I don't
mentioned
know if you've
earlier,
heard
if
of
the adhesion in the floor
the
of the mouth
saying
has
that it
been
takes a
there for
village to
two
raise a
weeks,
child.
it is
It takes a
suspicious.
village to manage
Refer.
a head and neck
If you've tried to give
cancer.
antibiotics for a week and
Thank you
nothing
for
has
your
happened,
attention.
maybe it's already time to
Okay, thank
refer.
you, Dr. Matsu and Dr.
Now, I don't
Kanyal,
know
for
if
that
you've heard
comprehensive
of
talk. We
the
now have
saying that it takes a village to raise a
411
child.
viewing
It takes a
by
village to
Facebook,
manage a
68
head and neck
by YouTube,
cancer.
and through the live stream,
Thank you for your
21.
attention.
Um,
Okay, thank you,
the
Dr.
floor is
Matsu
now
and
open
Dr.
for
Kanyal, for that
questions from the
comprehensive
audience.
talk.
Just type in your
We now
questions at the
have
Q&A chat box in the
411
right lower
viewing
corner of the live
by
stream window,
Facebook,
or type
68
in comments
by
in
YouTube,
YouTube Live,
and
or
through the
send
live stream,
personal
21.
messages to FB at Aging Webinars for Facebook Live
The floor is
viewers.
now open for questions from the
Um,
audience. Just type in your
Let me
questions at
see
the
if we have.
Q&A chat
Okay.
box in the right
You
lower
mentioned,
corner
of
of the
course,
live
that
stream
the
window,
most
or
common
type in
risk factor
comments
is
in
still
YouTube Live, or send
tobacco and
personal
alcohol.
messages to FB at
There are
Aging
many
Webinars for
mouthwash which are
Facebook Live
alcohol-based,
viewers.
right? Is
Yes.
that considered
There
there have been studies that showed an association. That's why
Okay.
nowadays
You
we've been
mentioned, of
recommending the
course, that the most
alcohol-free
common risk factors
mouthwash, and
include
manufacturers have been developing
tobacco and
alcohol-free
alcohol.
gargles.
There are many
So they have
mouthwash
to
which
look
are
into the brand of
alcohol-based, but
their
it's
yes,
not
yes, it has to
considered
be
there have been
alcohol-free,
studies that
preferably.
showed an
You
association. That's
mentioned
why
that
nowadays we've been
early
recommending the
detection. Is there a
alcohol-free
screening tool for
mouthwash, and
method
manufacturers have been
for head
developing
and neck cancer?
alcohol-free gargles.
Unfortunately, there's none.
So
Yeah.
they have to,
If you have the risk factors, heavy smoker, heavy
yes, it
drinker,
has
so
to be
any lesion, any
alcohol-free,
singaw
preferably. Okay.
you
You
feel in
mentioned
your inside your
that
mouth, you
early
should
detection. Is
worry.
there a
Or
screening
any growth,
tool
any
for
tumor you feel
method
in the
for
sides of your
head and
neck,
neck
probably
cancer?
a lymph node.
Unfortunately, there's
You should
none.
worry, go see a doctor if you
If
know
you
you
have the
have the
risk
risk
factors, heavy
factors.
smoker, heavy drinker,
But in
so
terms of
any lesion, any
biomarkers, blood
singaw
test
None.
for
you
screening,
feel in
None
none.
yet.
inside your
None
mouth,
It
yet.
you
really is
should
a higher
worry.
index of
Or any
suspicion.
growth,
We
any
come up
tumor
with
you
a
feel
lot
in the
of
sides of your
problems,
neck,
especially among
probably a lymph
smokers
node,
who already have
you
a
should
hoarse
worry, go see a
voice because
doctor
of
if you know you
smoking.
have the risk
So when they
factors.
get
But in terms of
when the voice
biomarkers,
gets
blood tests
worse,
for
they don't
screening, none.
notice it.
Yet.
Uh-huh.
It really is
So it's
Becomes
possible
normal
that
to them.
the laryngeal
come up with
cancer
a
is
lot of
growing
problems,
there because
especially
they're
among
not
smokers
paying
who
attention.
already have a hoarse
So
voice
it
because
really
of
is the high
smoking.
index of
So when they
suspicion.
But
get
when you stop
when the
smoking,
voice
does
gets
your
worse,
risk
they don't
diminish? Because say,
notice
for
it.
example, you've been smoking
So
for
it's
20 years
possible
and
that
then you
the
suddenly
yes that the
stop. You stop for
laryngeal
like
cancer
5
is
years. What
growing
is
there
the
because
risk?
they're
I've come
not
across
paying
books saying
attention.
that the cutoff time is
It
30
really
years.
is the
If
high
you
index of
quit smoking for
suspicion.
30
When you
years,
stop
your risk goes
smoking,
back to
Back to
your
zero.
zero.
risk will not
But
diminish.
here in
Say, for
PGH, we
example,
saw a lot
if
of
you've been
patients,
smoking for
40 years,
20
previous
years, and then you
smoker,
suddenly
still
stop
developing
for like
squamous cell
5 years,
cancer. So
Yes.
maybe
is the
the
risk.
risk,
I've come across
but yes,
books
when you
saying
stop
that the
smoking, the longer you
cutoff
stop
time is
smoking, your
30
risk
years. If
will
Will
you've
go
will go
down.
quit
down. It's
smoking for
true.
30
So
years,
the
your risk
earlier you
goes
quit, the
back to
better.
zero.
So since
But
the lining
here in
mucosa,
PGH, we saw
it's
a lot
the
of
no
patients,
mucosa which is
40
simple. That's
years
why you
previous
get
smoker,
Yes.
still
squamous cells,
developing
squamous
squamous
cell
cell
Yes.
cancer. So
anywhere
maybe
in the
the risk
upper
factors. But
aerodigestive
yes, when
tract
you
from
stop
your
smoking, the longer you
mouth
stop
down to
smoking,
your
your risk
esophagus.
will
Okay,
go
so
down.
we have a
That's true.
question here. Can you
So the earlier
describe
you
the
quit, the
procedure
better.
of laryngoscopy?
Since
Does
the
it
lining
entail
mucosa
anesthesia? What
is
are the
the
possible
mucosa which is simple, that's why you get
complications?
Yes.
Laryngoscopy, by
squamous cell
definition, is
cancer.
examination of the
Anywhere
larynx
in
or
the
the voice
upper
box. So
aerodigestive
usually
tract
a
from your
patient who is
mouth down
hoarse,
to
you
your
want to see
esophagus.
the movement of
So
your
we have a
vocal
question
cords.
here. Can you
Your vocal
describe the
cords,
procedure of
you have the right
laryngoscopy
side and the left
despite
side.
the
They should be
anesthesia? What
moving
are the
equally and
possible
symmetrically.
complications? Laryngoscopy, by
So if
definition,
you have
is
problems
examination of the
in voice, in
larynx
the
or the
quality of
voice
your
box.
voice,
So usually a
the ENT would
patient who
want to
is
take a look at
hoarse, you want
the
to see
larynx.
the movement of your vocal
We have a
cords.
mirror
Your
exam, the one
vocal
we do in
cords,
the clinic,
meron,
but
they
it's
have the
not
right side and the
magnified,
left side. They
and
should
you have
be
the
moving
problem with the
equally and
gagging
symmetrically.
because you have to pull out the
So if you
tongue.
have problems with
So
in voice,
sometimes
in
we
the quality
employ
of
the
your
use of
voice,
scopes.
the
Now,
ENT
scopes
would
is
want
like
to
a
take a look at
telescope. It
the
gives you
larynx.
magnification.
We
You
have a
can
mirror
either
exam,
use
the
a
one we do
rigid
in the
scope.
clinic, but
You
it's
insert
not
it through the mouth.
magnified.
There's a
And
camera and light
the
directed
gas
downwards to be able to look
is,
at the larynx, and then you have a
the
TV
lung
monitor.
cavity.
Sometimes you have a
So
flexible
sometimes we
scope
employ
about
the
the
use of
size of a
scopes.
spaghetti
Scopes
noodle.
is like a
It's flexible. You
telescope,
insert it
gives
inside your nostril.
magnification.
It can be
Another
a
use of the
little
scope,
uncomfortable, but
you
not really
insert it through
painful.
the
We can
mouth.
spray some
There's a camera and light
anesthetic, but it's
directed
an office
downwards to be able
procedure.
to look at the
That's the
larynx, and then
office
you have a
procedure,
TV
office-based
monitor. Sometimes you have a
laryngoscopy.
flexible
There's also
scope about the
laryngoscopy.
size of
We
a
employ wherein we bring up the patient to the operating room because aside from the larynx, we want to look at the surrounding areas also, like the esophagus, the piriform sinus, and if there's a mass, we want to get samples, then it's also a laryngoscopy in the operating room. It's under anesthesia, general
So
anesthesia.
most of the ENT specialists have this office
Not all, it can be
equipment.
expensive. Many of us would have it in the clinic, but there will be an additional charge. Some centers, they have an endoscopy center, like here in PGH, we have an endoscopy center. All the equipment are there, and then we schedule patients for endoscopy.
Not all, it can be
Okay.
expensive.
So are singers
Many
more
of us would have it in the
developing
clinic, but
this cancer?
Cancers, no.
Okay. Not
some
cancers.
centers
Yes.
they have an
But
endoscopy
singers
center.
do
Like here
get
in PGH, we have an
fatigue.
endoscopy
They get
center.
nodules, they get, but those don't necessarily degenerate into cancers. So video K and karaoke
Cancers, no.
in moderation
Not
are
cancers.
okay.
Okay, so now we're done with larynx. So the next question here is on thyroid cancer. What's the prognosis of thyroid cancer? Is still considered a friendly cancer? Is there a cancer which is friendly?
Yes.
Quote
Yes.
unquote.
I always tell my patients,
Okay.
I'm not saying it's a good thing, but if you have papillary, which I think is the probably one of the most behaved cancers, but there are aggressive papillary cancers also. So the best kind of patient, I mean the patient, cancer patient with the best prognosis will be a young female. Our cutoff age now is 55. So if you're younger than 55 and you get papillary cancer, you're still considered a low risk patient. You have the classic type of papillary cancer. We expect the 20-year survival to be between 98 to 100%. Still very good. It's a curable, you can be cured as long as you're a young female. It's a little more aggressive in males and in the older population. But in general, yes, it is a friendly cancer. Papillary and follicular a little more aggressive, but still considered friendly.
Specific risk factor for thyroid cancer?
Nothing. Not in food, not in iodine deficiency, maybe at most family history of cancer, but no really identified risk factors for papillary. Wala. It's not in the kinds of food you eat or in the kind of work you do. So no risk factors.
So the next question, back to risk factors. The use of e-cigarettes or vape associated with head and neck cancer.
Well, we don't know yet, but studies are coming out saying that well, because it's so new, so there we cannot directly say that this tumor was due to the e-cigarette, but because it is a foreign substance, a chemical in the body, then it puts the body at risk, just like a cigarette, for developing.
There have been studies, yes, exploring this, studying the effects of vape on and its relationship with cancer, but no conclusions yet.
Because case control studies would take
years.
So which is a higher risk? So back to that, tobacco, cigarette, or the e-cigarette? I guess we still
Yeah,
don't
we'll
know.
have to wait. We will have to wait. We'll give it a few years, then we'll see.
The next question here is there any cancer risk or malignant transformation of lesions with reflux esophagitis or laryngopharyngeal reflux?
Correct. Laryngopharyngeal reflux, there's been association already with the development of laryngeal and hypopharyngeal cancer, but it's not yet included in the risk factors. But there have been studies showing an association. So we advise patients with LPR or laryngopharyngeal reflux to get treatment and not just ignore their symptoms of LPR, because there's been studies associating the two.
So these patients usually go to an ENT?
I get a lot of patients in the clinic because their complaint is something, they have some sensation in the throat, some foreign bodies, some feeling of phlegm when there's no really phlegm. So yes, I think they would go to an ENT. I get a lot of patients in the clinic.
Okay. Are there patients or evidence associating again vaping in developing head and neck cancers? So again, I guess you've answered
Yeah,
this.
we'll have to wait
Yeah,
for.
there have been studies, yes. studies, but no conclusions
Yes, I
yet.
think they
So
would go to
better
an ET.
stop the
I
treatment.
get
Here,
a
no?
lot of
Side
patients that
effects
would
of
go to
radiation. What do you do with
Other
radiation-associated
patients, evidence
dysplasia?
associating, again,
Well,
vaping in
actually, the
developing
best
head and neck
thing to do
cancers.
there is
So
while the
again,
patient
same, I
is
guess, with
undergoing
answer,
Yeah,
we'll
radiotherapy,
have
we
to
do
wait
something about it
for
there
already.
have been studies,
So
yes, but no
we
conclusions yet. So
advise the
better stop the
gargles,
treatment.
here, side effects
hydration,
of
because
radiation.
hydration
What do
really,
you do
really
with
helps.
radiation associated
And it's
dysphagia?
important that the patient
Well,
eat
actually, the best thing to
well.
do there is
So I know
while the
that's hard
patient is
because
Yes,
they
because they
can't
develop,
swallow. Yeah, they develop
Ulcers.
so
ulcers. And then
we
it really becomes hard
advise
because
the
the mouth gets
gargles,
dry. But they have to
hydration,
really
because hydration
hydrate
really
so
really
that it
helps.
won't be as bad.
And it's important that the patient eat
Hydration does
well.
wonders
So I know
for
that's
side
hard.
effects,
Yes,
for
they can
mediating side
develop,
So
effects.
does that mean any form of
Ulcers.
liquid for
ulcers.
hydration?
And then it really
What do
becomes hard
you
because the
recommend?
mouth gets
Actually,
dry, but they have to really hydrate
well, for
so
some of
that
my
it won't be as
patients,
bad.
I've I have
Hydration does wonders
I've had to
for
say
side effects, for
any
mediating
liquid
side
as long
effects.
as there's liquid, because some of them
Mm.
have such a difficulty
Yes.
that any
Actually,
kind of liquid is better than no liquid.
well,
Of
for some
course,
of my
water is
patients,
the best. It's the
I
simplest. It's easy
I
to
have
find, but
I've
sometimes
had to
buko
say
juice helps
any
them
liquid
out.
as long as there's liquid,
My
because
problem
some of
with
them have
chemo and
such a difficulty
radiotherapy is that it
that
affects their
any
taste. So
kind of liquid
sometimes
is
the
better than no
juices that we
liquid.
give, even fruit
Metallic,
Of
no?
juices,
They
course,
have
water
they
is
have a
metallic.
bad
the best.
taste.
It's the
So it
simplest, it's easy to
really, you
find,
really
but
have to work. I work with my
sometimes
patients
buko
to help
juice
them look
helps
for
them
some kind of
out.
liquid that is
My
acceptable to their
problem with
palate.
chemo and radiotherapy is
Sometimes,
that it affects their
some
taste.
patients,
So
their chief complaint
sometimes
is
the
dysphagia
juices that we
already,
give,
like
even fruit
laryngeal,
juices,
hypopharyngeal
they
cancer.
have a
So to
bad
begin
taste.
with, they have dysphagia
So
already and
really,
some
you
pain on
really have to
swallowing.
work. I work
So
with my
sometimes when
patients
we
to help them look
anticipate
for some kind of
of
liquid that
even
is
more
acceptable
difficult
to their palate.
swallowing because of many
Sometimes,
factors like taste,
some patients, their chief
distortion.
complaint is dysphagia
So we
already,
warn
like
the patient
laryngeal,
that if
hypopharyngeal
your
cancer. So to
swallowing
begin with, they have
reaches a
dysphagia
really
already
critical level that you
and some
cannot
pain on
tolerate
swallowing.
even liquids,
So
then
sometimes
we'll put
when
in
we
a feeding tube.
anticipate
Feeding tube,
of
either through
even
stomach or
more difficult
nasogastric
swallowing
tube.
with many
So that's
factors like
another way
taste,
of nutrition
distortion.
getting inside the
So we
patient.
The
warn the
patients are
patient
not
that if
exactly
your
happy that they have
swallowing
feeding
Yes.
becomes
tubes,
reaches a
but
really
it's
What?
critical
better
level that you
than
cannot
not getting
tolerate
the
even
proper
liquids,
Yes, but
then
nutrition.
that's the
we'll put in a feeding
tolerance
Hydration.
tube.
is
Yes.
removed, eh,
Feeding
no?
tube,
Distorted
either
Plus
ones.
all
some sort
the
of
happiness that they
nasogastric tube.
derive from
Yes.
eating is
So
gone.
that's another way
So
of
that adds to their
nutrition getting inside the
psychological
patient.
The patients are not
makeup.
And that
exactly
side
happy that
effect
they have
goes
feeding tubes,
quite a
but
long
It
it's
takes a
Even
time.
after,
while,
even after
Yes,
treatment.
yes.
several
The
years.
dryness
Yes,
takes
Yes.
dehydration,
a long
yes,
time
distorted
plus all
to
the happiness
recover.
that they derive from
Therefore, that also
eating is
includes the
gone.
taste and the
So that
eating.
adds to
So
their
it is a problem.
psychological
Okay, there's a question
makeup.
here in connection with nasopharyngeal cancer. Having
even
nasal
after
polyps, does
yes.
that
The
give them a higher
dryness
risk to having
takes a long
nasopharyngeal?
time
If
for
it's
them
really nasal polyps
to
proven by
recover. Therefore, it
histopathology
also
after
depends
surgery,
on
then
the
no,
eating,
there's no malignant
which is a
transformation
problem.
of the true nasal polyps. But sometimes on physical exam, the doctor might think, this is just a nasal polyp, but it's only in the periphery. The
If it's
deeper
really
portion
nasal
would be something
polyps
else.
proven by
It might look like a nasal
histopathology after
polyp, but it's not
surgery,
really a nasal
then
polyp.
no, there's no malignant transformation
But if
of
it's
the
proven
true
by
nasal
biopsy, by
polyp.
after
But
removing
sometimes
everything,
on
that it's
physical
just a nasal
exam,
polyp, then no,
you
there's no
doctor might
malignant
think,
transformation.
So
this is
usually
just a nasal polyp,
there
but
might
it's
it might
only
be
in the
the
periphery. The
base of
deeper
the
Yes,
portion
polyp is
would be
might be
really
something
hiding
else.
something
deeper.
else. Like an
It might
inverting
look like a nasal
papilloma
polyp, but it's not
would
really a nasal
sometimes would
polyp.
look like a nasal polyp on
But if it's
endoscopy, on
proven by
physical
biopsy,
exam,
by
but
after
after
removing
surgery,
everything, that it's
it will
just a
turn out to
nasal
be
polyp, then
inverting
no, there's no malignant
papilloma. Now, inverting
transformation.
papilloma has a possibility of malignant transformation.
Yes,
So
might be hiding
papilloma, you
something else.
mentioned
Like an
papilloma, so
inverting
we come to
papilloma
HPV.
would
Okay.
sometimes
So,
would look like a nasal polyp
well, I'm
on
a
endoscopy,
gynae-onco,
on
so
physical
the
exam, but
establishment of
after
cervical
surgery,
cancer and
it will turn
HPV
out to be inverting
is very
papilloma.
good.
Now, inverting papilloma
Is
has
it
a
for
possibility of
head and neck
malignant
cancers?
Not
transformation.
yet. It will be HPV, but the strains, specific strains for head and neck cancer, HPV related head and neck cancer, and HPV related cervical cancer, different strains. So no, there have been a lot of studies, but
Not
not
yet.
yet
That's
proven,
it
not
will
like
be
in cervical
HPV, but the
And
cancer.
so
strains,
far, the relation is really
specific
just with
strains for head and neck
oropharynx
cancer,
Oropharynx,
and
HPV
not
yes.
with the
related
And
head and
not
neck
other
with the
cancer,
nose,
different
not with
strains,
the
and
oral
regions.
cavity,
HPV
yes.
related cervical
Which
cancer, different
goes,
strains.
so the
So
difference
no,
pala that we
there have
have
been a
is
lot of
that when you have, let's say, cervical
not yet
cancer, you can keep it.
proven,
Pwedeng
not like in
hindi
cervical
alam ng mga
cancer.
tao. But if
Yes.
you have
Yes.
head and neck cancer,
It's quite
it's
obvious.
very obvious. That's why the
Yes.
prosthetics
With the
very
nose, under the
important.
Yes.
So do you have prosthetics people
Yes,
in
um,
ENT and also in radio?
In ENT, yes.
yes, not all ENT departments in all hospitals will have a prosthetics team. Only the big centers. It started in PGH,
Yes.
but
Yes.
we've been training ENT residents also to become
Yes.
prosthetists also. And as they graduate and as they practice in
Yes,
the
not
different
all
regions of
ENT
the country, so
departments in all
slowly they're
hospitals will
starting
have
their own prosthetics
team. Only
lab.
the big
I
centers.
think
It
this is
started
where
in PGH,
radiology and
but
prosthetics and
we've
the
had we've been
prosthetics part
training
of the
ENT
ENT work very
residents
well
also to
together.
become
Because CT scans
prosthetists
are quite
also. And
important
as
for
they
that so that
graduate
they
and as they
can
practice in the
make the
different regions of the
prosthetic
country,
based
so
on the
slowly
CT
they're
scans.
starting
So
their own
plastic surgeons,
prosthetics
do they have a
lab.
role in this
I think this is where
reconstructive
radiology
surgery?
and prosthetics and the
No, plastic
prosthetics
surgeons
part
are
of the ENT work very
reconstructive
well
surgeons.
together.
So
Because
some of
CT
us ENT
scans
also do some
important for them so
reconstruction
that they can
procedures.
make
The
the
plastic
prosthetic
surgery
based
from the
on the
general
CT
surgery
scans.
So
department
plastic
also have
surgeons,
some
they have
people
a role
trained.
in this
But in
reconstructive
general, yes, the
surgery.
plastic reconstructive surgeons, they're the
Plastic
ones
surgeons are reconstructive
getting the flaps
surgeons.
to cover the
So some of
defects,
us
whether it's
ENT
soft tissue or bone
also do
defects,
some
and trying
reconstruction
to
procedures. The plastic surgery
restore
from the
some
general
kind
To
of
surgery
restore the
department also
symmetry
have
cement.
some
and
people
Yes,
trained.
the beauty of the
But in
face.
general,
yes.
yes,
So
the plastic
there is art
reconstructive surgeons,
Oh
their role
yes,
in
is
this
definitely.
in the
the
management
flaps
of
to
these
cover the defects,
cancers.
whether
Actually,
it's
it's this
soft tissue
art
or
that
bone
sometimes
defects,
gives
and
us
trying
problems
to
with the management because if a
restore
patient
some kind of
learns that he or she has to
yes.
lose
Beauty
a
of the
cheek
face.
Yes.
or a
There's art.
jaw,
Oh
then we have to
yes,
discuss with the
definitely.
patient what can be done.
Actually, it's
It's
this art that
getting the
sometimes
cancer
gives us
out versus having
problems
a
with the
disfigurement in the
management because
face.
if
So
a
it's always
patient
an issue with the
learns that
patient.
he or
Quality of
she
life
has
is
to
always
lose
we always
a
discuss the
cheek
quality of life
or a
impact
jaw,
on the quality of life
then
of
we
the
have to
patients for head and neck
discuss
cancer
with the
because it is very
patient what
visible.
can be
Not like
done.
cancers in the chest, abdomen, they
It's
can be hidden
getting
by
the
clothing.
cancer out
But
versus
here,
having a
no matter how very
disfigurement in the
good your
face.
plastic
So it's
surgeon
always an
is,
issue
there's
with
always the scar
Quality
There
of
will
there.
be
life is
some
all
scar.
we
Yes.
always discuss the quality of
That's
life
right.
So
impact on the
patient has to
quality of life of the
accept it
patients for head and neck
and
cancer because this is very
with help from
visible.
the
Not like cancers in the
team,
chest,
Even
abdomen,
something
they
as
can be
simple
hidden
as
by
well,
clothing.
simple
But here,
as
no
thyroid
matter how
surgery
very
Yes,
because
you
good
it's
the
have a
easy
plastic
line
to
there.
surgeon
hide
is,
actually the
there's always
scar,
the
but
scar. There
some
will be some
patients
scar.
yes.
don't like
In
to
some
admit.
cultures, like
So
yes, in the
patient has to
Philippines,
accept it,
Filipinos generally
and
accept a thyroidectomy
with help
scar
from
here.
the
Filipinos not
team,
very
even something as
adverse to a
simple as the
scar. Anyway,
patient
the scars in the neck they heal
thyroid
very well.
surgery
So
because
after
it's
a year,
easy
it
to
won't be very
hide
visible
actually
anymore.
the
But in some
scar, but
cultures, in some
some
countries,
patients
especially for
yes.
women,
don't like
In
it.
their
some cultures, like yes, in the
idea
Philippines,
of beauty
Filipinos
is a
generally accept a
scarless body.
thyroidectomy scar here.
So
Filipinos not
surgeons in those
very adverse
countries
to a scar.
they
Anyway, the
approach
scars in the neck they heal
thyroidectomy
very
from the
well. So after a
axilla,
year, it
from
won't
inside
be
the
very
mouth, from
visible
behind
anymore.
the
But in
ear,
some
Just
just to
to
cultures, in some
hide.
avoid
countries,
a
especially for
scar in the
women,
anterior neck. No,
their
so this is the sample is a
idea of
thyroidectomy.
So
beauty
which
is a
brings me
scarless
to the
body.
question, minimally
So
invasive
surgeons in
surgery
those
for head and neck
countries,
cancers.
they
Not,
Yes,
approach
yes.
yeah,
It is
We have
thyroidectomy
done.
from
minimally
the
invasive
axilla, from inside the mouth, from
surgery
And
for
behind the
less
ear,
thyroid,
just
scar.
to
but it has to
avoid
be a small
a scar
tumor.
in the
yeah.
So
anterior neck. No,
again,
so this
if you
is
catch these
sample
tumors
is
early and
early, which
smaller,
brings
the
me to the
morbidity of
question:
the procedure,
minimally
the
invasive
cosmetic
surgery
disfigurement
for
or
head and
deformity,
neck
if ever there
cancers.
will be, it
Yes,
will be very,
yes,
very
we have
minimal
minimally
or almost
invasive
none.
So how long are the surgeries?
surgery for thyroid,
These
but it has to be a small
surgeries for
tumor.
these tumors.
So
How long
again,
you
Now
should do
if
it? An
the
average.
tumors are early
Try
and
anywhere
smaller,
from six
the
hours
morbidity
to
of the
about
procedure, the cosmetic disfigurement or
uh,
If you have
deformity,
15
reconstruction,
hours.
if you
be
have
Yeah.
to
very, very
get
minimal,
skin from the
almost
lateral
none.
thigh, it can take as long as 8 to 12, sometimes 15
15
hours in the
At
operating
hours.
times
room.
we share OR
How long
rooms
this
with
is?
Yes,
How depends
yes.
on
PNP, so we don't have
So
to
it's
follow
really
you.
a long procedure, and usually several teams are go
if
in.
you have
15
reconstruction, if you
So,
have
so
to get
the
skin from the
multidisciplinary
lateral
team
thigh, it
in
can take as
PGH is
long
well
as
established for
8 to
this,
Yes, for
12
head and neck
to
Very,
15
cancer.
very
hours
well
in
yes.
the
So
operating
established.
room.
you review all the cases
Yes. So
that will be
And
undergoing
long
treatment.
well,
procedure, and
aside from
usually
just
several
reviewing
teams
it, we
are
learn
go
a lot
in.
from each other. Especially with pathology, we have a pathologist there, so everything that is new
For head and neck
in
cancer.
immunohistochemical
Yes.
staining, we learn about that. So it's a very good
and
experience
well,
for all
aside
the
from just
doctors
reviewing
because
it,
we
we
learn
learn a
about each
lot
other's
from each
specialties.
other.
And in the
Especially with
end, the
pathology,
one
we
who
have a
benefits most is
pathologist
the
there,
patient.
so
Yes, that's right.
everything
This
that
So
is
is
a
new
multidisciplinary
in
Yes.
So even squamous cell
immunohistochemical
carcinoma has
staining. We learn
evolved into
about that.
several
So it's
things
a
based
it's a
on
Yes,
very good
immunohistochemistry.
yes.
experience for all the
It
doctors
used to
because
be
we
that it
learn
was so
about each other's
simple that it's
specialties.
just
And in
poorly
the end,
differentiated,
the
well
one who benefits
differentiated, but
most
now
is
they
the
have
patient.
subcategories
So
that are actually changing the way that we manage
So even squamous
patients.
cell
So
carcinoma has evolved
for
into several
some tumors, there
recently.
is that possibility of
yes.
less
It
radical
used to be that it
radiotherapy,
was so
fewer
simple that
days,
it's
or
just
because some of
poorly
these tumors we
differentiated, well
find have a better
differentiated, but now they
prognosis.
have
If they have a
subcategories
positive
that are
marker,
actually
they have a
changing the
better
way that we
prognosis, so we
manage
don't have to be as
patients. So
radical with their
for
treatment.
some
So there, we
tumors,
will
there is
change.
that
The horizon is
possibility of
changing.
less
Yeah.
radical
Okay, since
radiotherapy,
this is an
fewer
aging and
days,
longevity
or because
webinar,
some
now
of
what
these
age should we
tumors we
start
find have
worrying
better
testing ourselves
prognosis
for
because they
head
have a
cancer? You
positive
mentioned kanina
marker,
55.
they have a better
No, this is
So,
for
prognosis, so we don't
thyroid.
have to
No,
ah,
worry
this
there's
is for
about
really
that.
thyroid.
no
So
screening, no. So if we have the risk
the
factors, even
horizon is
we
changing.
get laryngeal cancers. The youngest
Okay,
I
since this is an
remember is a
aging and
17-year-old
longevity
female.
Oh,
webinar,
wow.
what age should we
Yeah.
She
start
was a
worrying
non-smoker,
testing
non-drinker.
ourselves
She's
for
only
head
17, but she
cancer? So
had
you
laryngeal
mentioned
cancer.
kanina
We had to do a
55.
total
So this is
laryngectomy.
for
So
thyroid.
So
There's
for
really
thyroid,
no
it's
really no
not as
screening, no.
common in the
So if we
younger.
have
It's
the
more
risk
common in
factors,
the
even
older,
we
in
have the
As
the
risk
we
40s
factors.
and
The
age,
youngest
above.
our
I
risk
remember
really
is a
goes up
17-year-old
But
because
it's
of
female.
all our
not. But it's not
exposures.
She was a
impossible in the
non-smoker,
young.
non-drinker.
Yeah.
She's only
Mm.
17, but
So
she
really,
had
the index of
laryngeal cancer. We had to do
suspicion
a total
should be
laryngectomy.
high for all,
So
especially the primary care
it's
physicians.
not
And
as
then there,
common in
well,
the younger. It's more
additionally,
common in the
remember who
older,
gets
in
I
the
think
the,
as we
40s and
age,
well,
above.
our risk really
who gets
goes
the
up.
dentures more
But it's not
often?
It's the older
In
it's
the
not
patients.
older
impossible in the
patients,
young.
and yeah, ill-fitting
So really, the
dentures
index of
or
suspicion
foreign objects in the
should be high for
foreign
all,
objects in the mouth. They
especially
put
the
you at
primary care
risk for
physicians.
And then there, well,
oral cavity
additionally,
cancer.
remember
So
who gets
that
the,
alone
well,
makes
who gets the
should make
dentures more
you
often?
should make the
Is the
patient
older
or the
patients
even the
who, yeah,
general
ill-fitting
practitioner more
dentures or
suspicious. Yeah.
foreign objects in
Another
the
question
foreign
here. Do
objects
dental
in the mouth. They
x-rays
put you
increase
at
the risk
risk
of
for
thyroid cancer?
oral cavity cancer.
Well,
So that alone
theoretically, no, because
makes it
you're
should
not
make
supposed to get
you
dental
should
X-rays
make the
often.
patient or the even the
Because
general practitioner more
again, that depends on the
suspicious.
number of X-rays that you
Another
have.
question
But then
here. Do dental
again, if you
x-rays
have
increase the
one
risk of
good
thyroid
panoramic
cancer?
X-ray and one or two
Well,
good intraoral
theoretically,
X-rays,
no,
that will not
because
affect your
you're
risk
not
for
Yeah.
supposed to
thyroid
You
get
need a
dental
lot,
cancer.
X-rays
thousands of
often.
Yes,
x-ray
yes.
exposures
So it
for
actually
Again,
should
that depends
be
on the
on the
number of X-rays
dentists
that
now
you
not
have. But
to
then
request
again,
too
if you
many
have one
X-rays.
good
hindi naman
panoramic
makaka-thousand
X-ray,
No,
x-rays
not a
for,
thousand.
let's say, root canal
No, no,
procedure.
X-rays,
no.
it
Should
will
not.
not
Right.
Should
affect
not.
your risk for
Yeah.
So,
thyroid
You need
Joey,
a
you
lot,
cancer.
mentioned you
thousands
can
of
have
Yes,
CT,
x-ray
MRI. So
exposures.
if the
so it
patient has,
actually
let's
should be
say,
on the
just a few
dentists now
pesos
that
in
not to
her
request
pocket,
too many
what would you
X-rays.
recommend to be
Not to have a
better for
thousand
these?
No, not
Well,
x-rays
to be
a
for,
cost
let's say, root
effective,
canal
the CT
no, no,
scan.
procedure.
Should
no.
not.
Right.
Should not.
Because with CT
So,
scan, you
Joey, you
can still
mentioned
see
you can
soft
have
tissue
CT,
and
MRI. So if the
bone.
patient has,
It's
let's
just
say,
that with the MRI,
just
you
a
see
few
soft tissue
pesos in
better, but
her
we don't
pocket,
see bone as
what would
well.
you recommend to be
So it's
better for
still,
us?
if given
Well,
a
to be
limited
cost
budget, CT
effective,
scan
the
would still
CT
be
scan.
better.
But as guide to surgery,
Because with CT scan, you
yeah,
can
for the
still see
ENT
soft tissue
surgeons,
and
you'd
bone.
be happy
It's
with
just
the
that
CT
with the
scan.
MRI,
Most
you
of the
see soft
time, but in
tissue,
some cases, not,
but we
and
don't
it's not
see
often,
bone as
but some
well.
cases we will need
So it's
both.
still, if given a
But
limited
more
budget,
often than
CT
not, it's
scan would
just
still be
Just the
CT.
But
CT.
as
We
guide to
rarely request for an
surgery,
MR.
Again, it
yeah,
would
for
be
the
best
ENT
if
surgeons,
the
you'd be
hospital or
happy with
clinic that
the
does the
CT scan.
CT
Most of the time,
knows
but
what
in
it's
some cases,
doing.
not,
There are
and it's
some
not
clinics
often,
that will
but in
just,
some cases we will
just
need
do it
both.
and not really take
But
into
more often than not, it's
consideration
just
what the
CT.
surgeon needs to
We rarely
know.
But
request for an MR.
So
again,
sometimes
it
they'll
would be
have
best
thick
if
slices instead of thin
the
slices
hospital
that
or
would have
clinic
helped
that does the
us.
CT
They will do
knows what it's doing. There
one
are some clinics that
centimeter
will
or
just,
so
just
that
do it
won't be
and
very
not
helpful. So it's
really
really in the
take into
technique of the CT
So
scan.
consideration what the
radiology
surgeon needs to
technicians are
know.
also supposed to be
So sometimes
experts,
they'll
no?
have
Well,
thick
if
slices
a
instead of
doctor
thin
has
slices that would have
questions
helped
about
us.
what kind of CT
They will
scan,
do
talk to the radiologist.
Yes.
one
When
centimeter
we
or
teach our residents
so
in
that won't be
PGH to be
very
very
helpful. So
specific
it's
when they
really
write out the
dependent on the
request form for
So
CT
surgeon.
scans, to
radiology
be very
technicians are
specific
also
because we
supposed to
cannot
be
always
Yeah.
experts
assume
in
that the
Well,
rad
radiology.
tech
if a
Yeah.
doctor
would,
has
Questions
be
questions
about
about what
concerned
kind of
about the
CT scan, talk
patient.
to the
Yeah. Yes.
radiologist.
They might do just a
when we
decahon or a
teach our
checklist.
residents in
So
PGH to
we
be
try to
very
be
specific
specific.
when they write
You
out
mentioned
the
betel nut.
recommended CT scans. To be
There's
fairly
still many
specific because
Yes,
using
actually.
betel
But
nut.
it's a dying practice, no?
Oh,
When I was still
you
in
know,
training,
be
a lot of the
concerned
patients with
about the
oral cavity,
patient
most of them when you ask them, yes, they do betel nut chewing, nga, or even inverted cigarette smoking. Yung the inside, the cigarette is inverted. But this past years,
They've been decreasing.
it's yes, the
But
practice is
in the
decreasing.
province where betel nut is still available, it's still there. But the ones who take up the habit, I mean, they're older.
Yes.
So they're usually those who started betel nut as young people who just really can't kick the habit. We haven't really come across young people starting
Yes.
that habit.
In Taiwan and India, it's still very rampant. Even school age children, grade school age children, they start on betel nut. India, especially India. But in Taiwan, even teens in their, I mean, young adults in their 20s, they start betel nut in the provinces.
Yes.
So just to review, no, very important is the signs and symptoms.
Yes.
So
Yes.
mass,
Mass,
In
bleeding,
Taiwan, even
hoarseness, and wounds that are not healing
Inside the
on the
mouth.
tongue
Yeah.
and the floor of
The
the mouth, the
singaw.
gums,
Yes.
the singaw that do not heal.
Yes.
Bleeding from one side of the nose,
mass,
or a chronic, repeated rhinorrhea, a cold that doesn't solve itself.
Inside the mouth.
Those are signs
The
of
singaw,
that. It just means that I have to see a doctor.
yes.
Yes.
So I
It's not always infectious. Also, antibiotics will not. We get,
rhinorrhea, a cold that doesn't
Okay,
solve
so I think we learned a lot from this afternoon session. Now, in summary, we learned from the webinar today, of course, the epidemiology of head and neck cancer, 6 most common. You've enumerated the risk factors. The most important, of course, is tobacco, alcohol, betel nut chewing, oral hygiene. Thank you for reviewing anatomy. Of course, the signs and symptoms, the thorough history and PE, very important. The diagnostic procedures to arrive at by diagnosis, the imaging, of course, the additional metastatic workups, and of course, giving the appropriate treatment. Mostly it's surgery, except for nasopharyngeal CA, which is more for radiation. And then very important is the multidisciplinary approach to this, to the management of this cancer, no? Because you have to bring back these patients to be able to go back to life, no?
Yes,
Part
yes,
of
yes.
and be functional in their society, So thank you again very much,
Thank
Doctors
you.
Jen
Thank
Matsuo
you.
and Joey Canyal, mga kababata. We would like to thank our sponsor for today's webinar, Merck Sharp and Dohme. Please tune in to our next webinar on September 6. Learn about asthma and COPD in the elderly from Dr. Irene Wang. We would like to invite everyone to Brillante 29. That's tomorrow already. More luminous through time. You may still get tickets. Visit our Facebook page at facebook.com/Brillante2019. Catch up also the UP Med webinars. We have one this coming Monday, Usapang Antibiotics. We would like also to thank the CSES for sponsoring our 85th year anniversary. With that, we close this afternoon session of the Aging and Longevity webinars of the Mu Sigma Phi sorority. We'd like also to thank the CSES for sponsoring our 85th
The questions come from the same people lang eh.
Oo nga, kaya ako. Pero malaki na
and longevity.
Depende na yan.
Depende sa topic.
Pero marami pa rin na tayo na-discuss.
You're also very
Marami kang plastic questions.
Hindi, actually,
Kalimuha ko sa pala. Nagkukuha ko na yan lang. Habang nagsasalita kayo. Summarize. It's the one that I'm
Yes, Michelle.
Our certificate.
Wow, thank you, thank you.
Award from the
Yeah.
Postgraduate Institute of Medicine.
Use my board taken your attendance.
Management.
Answer evaluation.
Actually, patch mo. Wow, okay.
So,
Yun na nga, more can come.
Yes.
More can come.
More can come. Very important ito.
Here is the
Wow, naman.
Kasi inedit pa namin to, so
After
huwag nyo nang
receiving
gamitin
the
yung
sheet
data.
for today's
Ito na lang.
The certificates will then be emailed to your registered email addresses
Oh,
within
and also,
24
kasi like yung
hours.
multi-kamustahan ng September
Here is a
19.
quick
It's going to be
list
held
of
at Avid
upcoming
for more
conferences.
details. Please check it out.
Thursday.
Thursday yun. Oo nga, naman ko lagi
Nasa
ang
Quezon
Thursday.
City na.
Hindi yun.
Asan si Wen na wala na?
Mukha, I don't hear her anymore.
All webinar recordings will be viewed at YouTube.
Di ba pala scholarship mo lang?
Updates. Please
Ako
check
pa
our
ang
Facebook
pinag-ano nyo ng
page at
service. Grabe. Wag ako sa
facebook.com/Hypopharynx
service.
and our
Nahihiya
Twitter
ako. Bali wala yung ginagawa kong service compared to the
Get your
others.
copies now.
Today's webinar recording
Ako,
and all webinar
hindi naman
recordings
ako
may be
second
viewed
food
at
at
YouTube.
scholarship ako. Have a great day.
Okay, congratulations.
Girls Book. Get your copies.
Okay, okay.